Just wanted to start off by saying thank you for attending our journal club today. For all those who don't know me, I'm Nicole Sanders, one of the second-year pediatric residents. And I'm working today with Dr. Cerra, who's one of our pediatric residents as well. And we wanted to thank Dr. Jaimes for helping us with this presentation. To start off, of course, we have no financial disclosures. So today, our objectives that we will be working towards while looking at this article include we're going to practice formulating a specific clinical question and understand the study design, most likely to yield a valid information about a prognostic question using the PICO-TT format. We also want to appraise the article that we've chosen today and understand the uses and limitations of cohort studies with the help of the CAT format. And then one of the things that we want to focus on today is discussing and contextualizing the concepts of odds ratios and confounding variables, and then distinguish important factors in the determination of internal validity of cohort studies, and finally determine the external validity of the article and the applicability in the clinical practice. So in our search for an article for today, we came across an interesting article in a supplement of the December edition of the Pediatrics Journal. And this article today is discussing breastfeeding and asthma outcomes at the age of 6 years using the Generation R study. It was originally accepted for publication in the Pediatric Allergy and Immunology Journal in April of 2016. And so this article was of interest to us because it kind of addressed the question of whether breastfeeding influences the development of childhood asthma, as there have been previous studies, including a meta-analysis of about 775,000 kids from about 100 observational studies that showed that prolonged and extensive breastfeeding was associated with decreased risk of asthma symptoms in early childhood. So using our PICO-TT format, our patient population that the study was focusing on is children, which is, of course, most of us are pediatricians in here, so that's our main focus. The intervention or exposure that was looked at was, of course, breastfeeding, and then this was compared to not breastfeeding at all. And then the outcome that we looked at was various asthma outcomes that they chose for the study, which we will discuss further later. And then we determined that this type of question was a prognostic question, and so the best type of study to look at prognostic questions is a cohort study, and the best of that would be a prospective study, which luckily we found. So this study was conducted as a population-based study, and it was a prospective cohort study, as I already mentioned. It was embedded in a larger study called the Generation R study, which followed patients from fetal life through young adulthood, and these are patients in the Netherlands, specifically in Rotterdam, and it was approved by the Medical Ethical Committee. So in this study, they recruited patients from eligible mothers who were in the resident area, so in Rotterdam, and were planning on having a delivery date somewhere between April 2002 and January 2006. So overall, this came out to be a little more than 7,000 total patients in the cohort. And they did obtain informed consent at that time. They did aim to enroll the mothers as early as possible, so generally before 18 weeks of gestation, but were willing to enroll them up to birth as well as in their early, the children's early newborn visits. And there was no exclusion criteria that was talked about in the study specifically, so there's nothing for me to mention as far as exclusion criteria. So just to talk a little more about the methods in this article, so to determine breastfeeding and breastfeeding exclusiveness, they obtained detailed information about breastfeeding through questionnaires that they collected at 2, 6, and 12 months of age. And then through these questions, they classified various different things. So they classified whether the patient was ever breastfed versus never breastfed. They also looked at the duration, if a patient was breastfeeding, the duration for which they were breastfeeding, and grouped that as less than 2 months, 2 to 4 months, 4 to 6 months, or greater than 6 months. And then they looked at whether or not a child was exclusively breastfeeding during this time, and that was defined as the age at which either infant formula, any other type of drink or food was introduced. And they chose the endpoint of 4 months. So they were broken down into non-exclusively breastfed for 4 months versus exclusively breastfed for 4 months. And this makes sense kind of looking at the AAP guidelines that we use here. We usually suggest that somewhere between 4 and 6 months we start introducing baby foods and rice cereal. So after 4 months, we're not too concerned about whether breastfeeding has an exclusive effect on anything. And then to go into more detail about the asthma outcomes that they looked at, so they determined a lot of these asthma outcomes at the mean age of 6 years old, one by assessing lung function testing, where they determined the airway resistance, or what they, in the tables you'll see it as RINT. And this was during tidal expiration, and it's measured as kilopascals per liter. And then they adjusted for sex and height of the baby at that time when they calculated the Z-scores. They also assessed the fractional exhaled nitric oxide level, which, as some of us may or may not know, is a measure of the eosinophilic airway inflammation. And just to kind of go more into detail about that.
So the fractional excretion of nitric oxide is a measurement of the fractional nitric oxide in an exhaled breath, and it is a quantitative and non-invasive method to measure eosinophilic airway inflammation. And if you look at this table, you can see that low levels mean that eosinophilic inflammation is less likely, and the higher up you go, or the more you change in a short period of time, the more likely it is that you have eosinophilic inflammation of the airway. And what this is good at predicting, better actually than any other type of pulmonary function test, is whether you will benefit from inhaled corticosteroid therapy. So FeNO is more consistent at this prediction than spirometry, methylcholine challenge, or response to bronchodilators.
So just to continue with other asthma outcomes that they did look at, they went ahead and assessed symptoms such as wheezing using questionnaires that they adapted from the International Study of Asthma and Allergy Childhood Questionnaires. And they obtained these questionnaires at a time point between 1 and 4 years of age and at 6 years of age. And these questions, they were able to categorize whether patients were wheezing yes or no, and then determine wheezing patterns based off of the time of onset of wheezing, as well as if they subsequently had wheezing occur or not. They then broke them up into groups of early wheezing pattern, which meant that they started wheezing early, before 3 years of age, and only at that point in time. The late group was categorized as wheezing somewhere between 3 and 6 years of life, and the persistent group was they started wheezing at 3 years or younger, and then they also had wheezing from 3 to 6 years of age. The questionnaire also looked at or asked parents whether or not their child was recently or was ever diagnosed with asthma by a physician, as well as if there was presence of wheezing in the past 12 months. They also try to take into account some confounding variables, which we'll talk more detail about as far as what that is, by obtaining maternal information via questionnaires when they were first enrolled. So questions that they looked at were maternal age, mom's pre-pregnancy BMI, educational level of the mom, maternal history of whether she had asthma or ACP at any point in time, and whether she had any pets. They also assessed whether there was smoking, there was maternal smoking during pregnancy at first, second, and third trimester, and then just grouped it as yes, they did, or no, they did not. They also tried to look at psychological distress in the mom using the Global Severity Index, and then used midwife and hospital registries to gather birth information such as sex, gestational age, and birth weight. And then using questionnaires at the age of 6, tried to determine whether there were any inhalant allergies like dust mites, and whether or not children had any lower respiratory tract infections during the study. Before I go on, does anyone have any questions about kind of what we've talked about thus far? Yes, Dr. Lula.
Are there no fathers?
Huh? They only collected maternal information during the study, which is something we'll talk about later. Yes?
Is that test impacted at all by like the they're currently using like inhalers, like
We'll also consider that later on. Anything else?
How many people in this room had ever heard of fractional excretion of nitric oxide as a test for that?
They talk about it in home on occasion. I don't know if they do it frequently. I haven't heard of the kilopascals per 1
Okay. So just to continue with the methods, they did data analysis using a multivariate regression model to examine if there was any association between the duration of breastfeeding and exclusiveness of breastfeeding with rinse, which what we talked about was the airway resistance in the lungs, the fractional excretion of nitric oxide, wheezing patterns, as well as whether or not they had a current diagnosis of asthma at the age of 6 years old, and then made sure to adjust for those confounding variables that I just previously talked about. And they used a confidence interval of 95% when looking at the effect of the change.
So at the beginning of this study, actually throughout this study, 5,675 children were included. This is about 60% of the children who were born during the study time frame and are enrolled in the study. The initial number being 9,745 kids and 7,893 that came back for postnatal follow-up. Because this is a population-based study in an area with universal health care, they could invite all mothers having children within that time frame to be in the study. And so then they can pull out those who have the data that they are looking at specifically, so who had filled out and sent in all the questionnaires that they needed and had not restricted consent so that they would not fill out questionnaires and didn't miss appointments. So really the people that we are missing from this study, those lost to follow-up, had certain factors in common, maternal factors of being younger, lower education, higher pre-pregnancy BMI, higher prevalence of smoking, higher psychological distress, and the children were more often non-European in ethnicity, born younger with lower birth weights, and had more respiratory tract infection. So I will talk about how those might be confounding at a later point.
Okay. So we'll get into the tables of the study. So the main results. So this first table is looking just at the characteristics of the mothers and the children that were included in the study. And I know it's kind of small and hard to read. So we'll focus on the maternal characteristics first. So just looking at that, we can see that the average maternal age was somewhere around 31 years old, and the standard deviation was about 5 years from that. I also wanted to point out that about 53% of the population had higher level of education, and then about 38% of the mothers had some type of history of asthma or atopy. And then one of the main things that we like to ask our moms about birth history is whether or not they were smoking during pregnancy, and about 14% of them did have some smoking during pregnancy.
this at the research visit at 6 years or whatever, or is this current?
So this is information gathered through the maternal questionnaires when they enrolled, as well as at time of enrollment. And then they did questionnaires about smoking during the pregnancy.
And then one thing is that the smoking during pregnancy is actually clearly identified as a risk factor for asthma increase. So that's why they have to take that into account and not forget about whatever they already know, right? So it's one of these markers that is already well established.
So then we'll focus on the child characteristics on the table. So just to look at, about 50% were female, 50% were male. The gestational age of the patient when they were born, on average, was 40 weeks gestation, but they did include patients from 26.7 weeks of gestation to 42.9, which is equivalent to kind of our patient population of potential live births here. And then approximately 71% had a European ethnicity, and looking at kind of overall non-Hispanic Caucasian race here is about 63%, so very close. And then also to point out, there was a high level of breastfeeding ever at 92% in this patient population. And then of the patients who ever breastfed, about 10% of them, of all the patients that were included, about 10% of them never breastfed. And of the ones that did breastfeed, 20% only breastfed for less than 2 months, which that could be from like 1 day up into 2 months of life. 16% breastfed from 2 to 4 months, and about 9% from 4 to 6 months, and they had about a quarter of their patient population that breastfed for longer than 6 months. And when they looked at exclusively breastfeeding, about 65% of their patients breastfed, but it was non-exclusive, compared to a quarter that exclusively breastfed for 4 months. And then just to kind of highlight their results for just wheezing. So half their population never wheezed at all per their questionnaires. 28% had early wheezing, so at 3 years or earlier. For about 5% were later on in life, between 3 and 6 years of age, and 13% had persistent wheezing. And overall, 3% had a diagnosis of current asthma, which you would think that if 13% had persistent wheezing, that would have been a higher number. So just food for thought for later. And then we move to the second table in the study, and this was just looking at the association of breastfeeding with whether it had any effect on the fractional excretion of nitric oxide or airway resistance. And they use Z-scores here, so just to kind of remind you that if the Z-score, the confidence interval of the Z-score includes 0, then there's no significant difference. So as you can see, they found that compared with children who ever breastfed, those that were never breastfed had lower fractional excretion nitric oxide levels, and you can see that with the value of -16 and a p-value of 0.01 with the 2 asterisks there, and it does not cross that 0 value. They then found no significance when they were looking at the airway resistance between the 2 groups. And there was also no association with the duration or exclusiveness of breastfeeding with the fractional excretion or of nitric oxide or the airway resistance. Any questions before we move on from these 2 tables? Does that all make sense? Okay. So table 3 is then looking at the association of breastfeeding with the wheezing pattern and current asthma. So in this table, they used analysis using odds ratios. So just to go into more detail about odds ratios. So odds ratios are used as a measure of association between an exposure and an outcome. or looking at the odds of an outcome occurring given a particular exposure compared to the absence of that exposure. So if the odds ratio number is greater than 1, that means that the exposure is associated with a higher likelihood of that outcome compared to if the odds ratio is less than 1, you would think that there's less likelihood for that to occur. And once again, looking at the confidence interval, you do not want that confidence interval to cross the value of 1. So does anyone have questions about that concept before I explain this graph? No? Okay. So what they showed here was that never breastfed children had an increased risk of early wheeze and current asthma. Never breastfed children had an increased risk of late and persistent wheezing, as you can see by the odds ratio of 1.69 and 1.44, with a p-value of 0.01. And then looking at the duration of breastfeeding, what they found was if patients were breastfed in less than 2 months, they had an increased risk of early wheezing and current diagnosis of asthma. And then they show in this table that, and explain in the paper that the longer the duration of breastfeeding was associated with early wheezing and current asthma. However, they never really explained their definition of how they determine this information in their table, so it's really hard to interpret right now. And we did look at the supplemental information as well and couldn't really get any better idea. So unfortunately, I don't have any insight into this portion of the table. So we'll go to the last part. And so the last part is looking at the exclusive, whether breastfeeding was exclusive or not and its effect on wheezing patterns. And what they showed here was that if you're non-exclusively breastfed, children had an increased risk of early wheezing compared to those who were breastfed exclusively for 4 months. And so,
okay, so we also pulled some tables out of the supplemental information just to look a little deeper. And this table talks about the association between asthma and breastfeeding when you adjust for early respiratory tract infections. So as you can see in the top section, those who never breastfed compared to those who did breastfeed, they had a higher risk of early, late, and persistent wheezing, and that had a p-value of 0.01 and is statistically significant. And then more specifically, if you go down to duration of breastfeeding, you can see that those who breastfed less than 2 months were more likely to have early wheezing and persistent wheezing, as well as current asthma diagnoses. And those who breastfed 2 to 4 months were still within that higher risk group for early wheezing. And this actually had a p-value of less than 0.005, making it a very significant correlation. Okay. And the previous table was adjusting for early respiratory tract infections prior to age 4. This table looks at infections between age 4 and 6, which in the end did not have as much of an effect as early infections, as much of an attenuating effect. So you can see here that the only significant effect of late respiratory tract infections was an increased risk of persistent wheezing in children that breastfed for less than 2 months, with a percent change of -33.5 and a p-value of less than 0.01. So this is our appraisal of the article. We'll look first at internal validity. Was the defined representative sample of patients assembled at a common usually early point in the course of their disease? So the answer to this is a resounding yes. This study started at birth before patients had any chance of developing asthma, so we got to see their presentation, whenever that may be. Sorry. And that is a perk of this type of population-based cohort study where you can enroll everyone available that is willing to enroll. In terms of whether follow-up was sufficiently long and complete, this is a little bit more difficult of a question to answer. Yes, it is the longest study that we have looking at the development of asthma to the age of 6 years. However, it would, of course, be interesting to follow kids beyond 6 years because they do present later in childhood sometimes. So hopefully this study can go back later and look at the data as the kids age. And then another issue that we wondered about was many of the patients who were lost to follow-up did have characteristics that have a higher risk of having asthma. As we talked about earlier, mothers were younger, mothers were more often smokers, children were more often low birth weight and early gestational age. And were the outcome criteria objective? So in theory, RINT, the airway resistance, and FeNO2 are objective measurable criteria. However, their clinical significance in this study is a bit questionable because we don't know if the children were being currently treated for asthma at the times of data collection. And then the diagnosis of asthma and current wheezing are a bit less objective. Those were collected from parents. Is your child wheezing? As we know, we don't always get the most correct answer, and diagnosis of asthma is based on provider. And then questionnaires are not really considered objective measures. So we had a little bit of everything. And then if subgroups with different prognoses are identified, did adjustment for important prognostic factors take place? And we had to say somewhat. They were adjusted for birth weight, gestational age, and those can be used as stand-ins for premature babies having respiratory issues, NICU stays, intubations, adjusted for inhalant allergies, and respiratory infections, as well as maternal smoking. However, they did not adjust for family history of asthma in fathers or the rest of the family, and they didn't adjust for smoke exposure in the home. So we're going to talk a little bit about confounding variables. These are extra variables, third variables, that could affect both the independent and dependent variables that are being studied, in this case, breastfeeding and asthma. And this can affect the internal validity of the study and can lead to altered conclusions at times. So the study did adjust for a large number, but not all such variables. As I just said, family history of asthma besides the mother was not taken into account, as was smoke exposure in the home or lower socioeconomic status, all of which we know can be associated with asthma. Am I talking too fast for you guys? Okay. And then what are the results of this study? We saw quite clearly that you have a higher risk of developing asthma if you were never breastfed, if you had a shorter duration of breastfeeding, or were not exclusively breastfed until the age of 4 months. And this effect was somewhat attenuated by lower respiratory infections early in life, which is perhaps due to the protective effect that breastfeeding does have on infants developing lower respiratory infections in early life. So this leads to our other type of variable, a mediator, which is another type of third variable that helps to identify and explain the mechanisms that lead to an observed relationship between the independent variable and dependent variable. And in this study, that was the early lower respiratory infections. And this is because we do know that breastfeeding provides the baby passive antibodies from mom and does have a protective effect against lower respiratory infections. So it is mediating the effect that the independent variable is having on the dependent variable. So we're still talking about the results. How reliable do you all think the FeNO2 and airway resistance were in determining whether the children had asthma? Opinions?
Just because it's not done in the States doesn't mean it's wrong, but I don't know.
Wouldn't you expect that if fractional excretion of nitric oxide is only validated for corticosteroid, prediction of corticosteroid response, where you can have, presumably you have a subset then of children with diagnosed full-blown asthma respond and don't, and if you're really only looking at that subset, that's not a great marker for the, I don't know what fraction is corticosteroid response is not, but you're at least excluding however many that is from using that as an objective measure for asthma in general rather than subset of corticosteroid response to asthma.
Any other opinions? Okay, so we'll go into that a little bit. So it's a little bit inconclusive in this study. Let's start with talking about the FeNO2, which, as we know, isn't really used much in the States. They do talk about it in this study in a very specific way, because as we saw, a lower FeNO2 exhaled fractional excretion of nitric oxide was associated with having never breastfed. And the lower the FeNO2, the less eosinophilic airway inflammation you would expect. So that's not really what we expect looking at it. We would expect breastfeeding moms to have children who had lower FeNO2 rather than the opposite. So the way that the paper sort of went into explaining this, and this is more of a hypothesis on their part at this point, is that those who were breastfed had a lower chance of lower respiratory infections in early life, and those who were not did have more of those infections early in life, moving them from an eosinophilic type airway inflammation to a neutrophilic airway inflammation. So that was their hypothesis for the mechanism of how lower respiratory infections played into decreasing FeNO2 and perhaps attenuating the effect of breastfeeding on later developing asthma. Did any of that make sense to anyone?
What happened? Does that actually happen?
Which part?
Changing from eosinophilic to whereas specific process for asthma? Like, is that
So I do not know if that can happen, but this study was done by pulmonologists, and I would assume they wouldn't make that hypothesis if it wasn't how it happened. The way they wrote it, I don't have it right in front of me, but that does, it does, the way they wrote it does make it clear that that is a mechanism of airway inflammation that happens with lower respiratory tract infections. Sorry for the jokes.
No, but it's steroids, right? It's steroids. They try to explain it because they see the effects, but it's steroids. Okay? And then the question that, that Sam is trying to to point out with Clifton is really pointing out is this really a good objective measurement to actually diagnose asthma, right? Because asthma is a clinical diagnosis as far as we all remember, right? And then these measurements, are they good enough to objectively diagnose asthma? That's the thing. Now, if the kids have, like you were thinking, low dose steroids already, is that going to modify the SDNO2? Now, whether they treat it or not, we're going to assume they are. This is an advanced, well-developed country with universal health insurance. And they're not going to be bad control if they're known to have asthma. Hopefully, right, most kids are well controlled. It's like when they are well controlled, they're asthmatics or asthmatics. They go and have spirometry and they are normal. When they're non-controlled, they're not normal, right? So the airway resistance might be normal if they're well controlled. So are these objective measurements to really diagnose asthma? If they're well controlled, if they have low dose steroids ongoing, is that going to modify the results of these objective measurements? Most probably they will. So how good of an objective measurement are these to really diagnose asthma? It's probably very questionable, right?
Yeah. So exactly, that gets to the next point of airway resistance. Why didn't that have a measurable difference between breastfeeding and not, when we know that airway resistance is a big part of asthma? Well, were these kids being treated at the time? Because then we would hope to see a good effect of treatment and a similar airway resistance between those being treated for asthma and those without asthma. And then the study does say in the end that in part of their, these were our flaws and possible places we could do better. They do admit that spirometry is a better measurement of asthma, and that would have enhanced the study, but the calculation of airway resistance using RINT is more feasible in this younger age group.
Question about, and forgive me if this is already touched on. Mechanically, how do they calculate the airway with a RINT net? Like, is it some other, monitor on the kid's chest wall motion? Are they getting at, hey, it's hard to do spirometry in a 4-year-old, which, we don't do spirometry in 3-year-olds if they're not going to do it, right?
Right.
Is maybe that's the reason they're using these sort of not common to us metrics for all this in the first place?
It doesn't require the patients to have to breathe, we've all seen spirometry done in the pulmonology clinic, so they have to take deep breaths in and prolonged expiration. They can just breathe normally when they're doing these studies, and so you don't have to have the patient practice the technique over and over again to get a
mask that you put on the kid's face and you measure.
I don't know.
Flow or okay.
Sorry.
This would be curious
Yeah.
The only thing it says is airway resistance during tidal expiration, and then adjusted, and oh, by the way, there's a problem with the device you use, so we corrected for that.
Yeah.
There were in the paragraph.
May not have said, oh, by the way, but, okay. And then we did look at the external validity of the study as well. Can we apply this evidence to prognosis of our patients? So we can. We do have similar demographics as in this study. We do have a similar percentage of Caucasian individuals, 70%, around 70% in the study, around 60% in the United States. The gestational range of 26 weeks to 42 weeks, also very similar to our population. And then maternal factors such as maternal age and the fact that new moms are getting counseling on breastfeeding when they're having babies is similar in both places. Obviously, many more are breastfeeding initially at 90% in the Netherlands, but what can you do? And then that just adds to the things we can talk about in our visits with parents about breastfeeding, that, oh, hey, if you never breastfeed, there is a higher risk that your child will develop wheezing after 3 years of age and continue younger than 3 years of age and continue wheezing after 3 years of age. And the earlier you stop breastfeeding, there is a higher risk of asthma diagnosis at age 6 and wheezing in the early years of life. And then if you don't exclusively breastfeed until 4 months, there is a higher risk of this early wheezing. So non-exclusive, and the non-exclusive and shorter duration breastfeeding are associated with getting early lower respiratory tract infections, which does play a part in early wheezing, as we know. So these are some of our references. And do you guys have any questions? Dr. Whalen, let's take yours first. This one?
So what's the, you could take a little bit of information. You could say that never breastfeeding has a little bit, is a little bit worse than never breastfeeding by your late feeding or consistent feeding measurement. I could also try to say a little bit of breastfeeding was the worst possible thing here because that's the one that had the highest increased risk for Audrey to do a current asthma. What's the reference point that you're never breastfeeding or short duration compared to what?
Compared to, I'm sorry, could you add just that last part one more time?
So all these, the benefits versus risk of breastfeeding. So never breastfed or short duration of breastfeeding is compared to what?
So never breastfed is compared to ever breastfed in the tables, and the duration is compared by less than 2 months, 2 to 4, 4 to 6, greater than 6.
So more than 6 months.
The reference for comparing never breastfed with any breastfed.
Yeah.
The reference for comparing a little bit of breastfeeding was breastfeeding past 6 months.
Well, it was 4 months when, because of the exclusivity.
But look at the table.
Yeah.
Okay. Duration. So they were comparing to the 6 months.
Reference.
Okay, 6 months.
Reference C. More than 6 months. More than 6 months. So that's the table right there. More than 6 months.
Yeah. So reference is greater than 6 months.
Yeah.
Okay.
So yeah, when you're counseling, so I probably shouldn't say a little bit of breastfeeding is the worst possible thing you could do for your child based on this study. I should probably say compared to breastfeeding for a long period of time, breastfeeding for a long period of time is probably a little bit better for airway reasons. And not breastfeeding at all is probably worse than any bit of breastfeeding.
That would be the conclusion that I came to and that the study came to.
That's the best I could say from this study. Is that fair? Mm-hmm. And then, as you've already pointed out, there's many concerns about are we accurately measuring what does FeNO mean at baseline, let alone in a probably well-treated population, is a very good point. And they really don't break down the numbers of how many people they could have studied or who was included or why. They really they just refer back to the previous study that we have from this group, this Generation R study. You can find some numbers there.
So we did refer back to that previous study, and we did find that they did enroll. I have the exact numbers if you would like to hear them. Hold on 1 second. 9,778 moms in this town of Rotterdam. I'm not sure of the population. Matt, Brian? I thought you might know. Just kidding. Then that went down a little bit to 9,745 children produced. 7,893 that they were able to follow up with postnatally, but 598 of those restricted their consent to say we're not answering any questionnaires. So that is
that dropout group is a group that has some statistical similarities to others.
example, the educational level, higher means elementary school, finishing high school, and then higher education, it's, going to college. And the kids who were admitted in this cohort, which is actually a very accurate way of predicting a socioeconomic status. So it's comparable, okay? And this cohort has like 54% higher education, which is very high for population. On the low follow-up, it's only 25. So they have higher percentage of moms who had lower education than the ones who stay in the cohort, right? They were younger, gestational age was less. They were from other ethnic groups different than European descendants. So there are risk factors of this population that's missed that probably will put them on higher risk of having asthma just by themselves. But that itself doesn't invalidate the data. That will put less endpoints. So they will have less asthmatics than if they will have been in the cohort, right? But the data they're looking at, they're also controlling for, right? Now, the question about whether the child smoke or not smoke, that's, probably important, but I'm not sure if they have been validated as a variable that we have to control. Like maybe it's losing power when we put them together with the mom smoking, and the mom smoking is that one that actually stays, persistently be significant when they put it against asthma. However, they only investigated the smoking exposure during pregnancy, first, second, and third trimester, and not after pregnancy. And we've seen, everybody has seen it, how when they stop smoking, they are much easier to control, right, in real life. So there's not a question of whether smoking exposure, there's a question from our perspective where smoking exposure after pregnancy was even asked or even, controlled at all. So that's another good one. Now, just take into account this is a population study, so everybody is part of the sample. So having everybody part of the sample makes it a really good sample, right? So everybody who was born in Rotterdam for those 4 years were invited to be part of it, and they have a pretty good rate response for a population study. So it's not just this hospital, born in Carilion Clinic, but everybody born in Roanoke, right?
More questions? Yes, Omar.
Would it be better to show the cost effectiveness compared to existing things like that, or is it expensive to perform as well?
I have no idea.
I think it's expensive to perform. You have to go to the reference pulmonary lab to get it done. At least in this case, I'm in the Netherlands. I'm on Palm now, and we've talked about doing it for a handful of kids. But I think it's relatively expensive. Oh boy. This is pressure. I think it's expensive to perform. I think it's for severe asthmatics where you're having a debate of, is the parent over-reporting the symptoms, or is there a miscommunication of what the parent perceives going on versus what's actually going on in the kid, and your spirometry is sort of indeterminate, or your spirometry looks good, the parent says they're falling off the cliff, and you want more data to rely on of, do I need to escalate therapy in this kid or not? And then I also looked up the wrist impedance thing. So what they do for that is they wrap a monitor around the kid's chest, and then they stick a mask on their face. So they measure the respiratory effort and change in pressure of the thoracic cavity and correlate that with the volume of breath exhaled to then come up with a resistance number. And we have centimeters of water per liter in the States, but they use kilopascals and, SI standard units in Europe.
And the rest of the world.
Is that the main advantage of these two tests? They're non-invasive.
Yes, and also the difficulty on the performing of the test, right? Because they're younger than 6 years old. And I think that's the main reason why spirometry wasn't considered, because usually a spirometry technique is harder, like Nicole, Dr. Sanders was trying to explain. It's harder to produce the expiratory effort that you need that is good enough to actually make that spirometry valid. Further questions?